Welcome back. I hope you enjoyed this morning's session. I thought it was very interesting, and it was nice to see a very engaging panel discussion, so all good. So now we're going to have the DDL Annual Lecture. I always enjoy this because it's nice to find and recognize the real leaders in the industry and invite them to tell us more about what they know, what they've learned, and what they're currently doing. Okay, so the person who's got the DDL lecture this year is Mike Hindle. Mike Hindle is the Peter Byron Distinguished Professor in the Department of Pharmaceutics at Virginia Commonwealth University. Mike has published over 130 peer-reviewed papers, 1 book chapter, and has served as co-editor of 5 books. He holds over 10 US patents, 5 EU patents, and has been involved in the licensing with 2 different companies. I could read more, the list goes on and on, a very distinguished speaker. So Mike, we're very much looking forward to hearing from you.
Well, thank you, Gary, for the introduction, and I'd like to thank the organising committee. It's a great honour for me to be here to present the work we've been doing over the last few years, developing aerosol delivery technology to deliver aerosols to premature infants, who really are our most challenging and precious patient population. I put my disclosures up here. It's the 35th anniversary of DDL. I thought I'd better see where I was 35 years ago. Turns out I was just graduating as a pharmacy student and actually starting my drug delivery to the lung journey as well. I was actually starting my PhD project in Bradford. As you can see, I've hardly changed a bit. Even my mother doesn't recognize me. So as I thought about what I've been doing over the last few years, we've been always very interested in developing methods for estimating how much drug is being delivered to the airways, especially if we can develop methods that are going to be useful for regulatory purposes. I started off with Henry in Bradford developing a pharmacokinetic method, where we took a very simple non-invasive urine sample after 30 minutes, and that gave us a measure of the relative lung pulmonary bioavailability. In 1994, I moved to work with Pete Byron's group in Virginia Commonwealth University. My original plan was just to go over to the States to watch the Soccer World Cup, which was being held in '94, but those of you who remember, England didn't qualify that year, so I didn't get to see much of the soccer. But what I did do is spend the next 30 years working with Pete and his team, developing, a lot of the time, working on realistic in vitro testing methods, whether or not that was for nasal drug delivery or for oral inhalation. Pete taught me many things. Probably top of that list was always to work with good people. And I really hit the jackpot when one day Worth Longus came to the department and he gave a seminar. We went for lunch afterwards, and that was the start of our 15-year collaboration. I truly wouldn't be here on the stage today if it wasn't for Worth, for his intellectual contributions and his friendship. This really is the product of our research. Worth's a mechanical engineer. He specializes in computational fluid dynamics. So we use his simulations of lung deposition, of simulations of aerosolization, and we combine them with our realistic in vitro testing to help guide us to investigate how much drug is delivered to the airways of patients. This is one of the studies we did a number of years ago now. This was some work published by Renish Dalvadia and Jiangyin Wei, in which we used realistic mouth-throat models in combination with realistic breathing profiles to try and estimate the total lung dose that we're able to deliver to the lungs for a metered dose inhaler and a dry powder inhaler product. And you can see that by using a combination of physical models of different sizes, different shapes, in combination with flow profiles of different volumes and different rates, we're able to capture in vitro not only the average dose that we deliver to the lung that we measure in vivo using gamma scintigraphy, but we also capture that patient variability as well. And I think that's a concept that's really important as we look for realistic in vitro testing, the patient variability. Lala Goshahi's working on our efforts to develop nasal in vitro models as well. So on this slide here, you see a paper that we published recently. Prakash and Mohammed here led our efforts, where we're developing low, medium, and high nasal deposition models for both an adult population and for a pediatric population. Starting with CT scans of the patients, we then create 3D printed models, and then we screen those models to identify models that represent low, medium, and high deposition, again, to capture patient variability. And in this particular study, what we went on to do is to look at the population bioequivalence of innovator and generic nasal sprays in both the adult and pediatric population. Really want to, again, emphasize what we saw in the mouth-throat work. In order to capture patient variability, we need to use multiple models. This is some data showing the posterior nose deposition measured in 40 nasal cavities. So we took 20 subjects, adult subjects here. We sprayed 2 nasal spray products into them, Flonase and Flonase Sensimist, and measured the posterior nose deposition. And you can see that even in the most controlled laboratory environments, the posterior nose deposition varied between around 15% nasal deposition all the way up to over 90% nasal deposition. So if we really are to capture patient variability, we need multiple models in our realistic in vitro testing. This was some work performed by Ali and Sana a number of years ago. So the work I just described has all been funded by the FDA. And I think we're starting to see the fruits of that research now when we come to look at regulatory guidances. This is a guidance published in August 2024, and there are a number of new guidances coming out right now, where for the first time we see that the FDA, for its in vitro bioequivalence studies, talks about using realistic measurements of aerodynamic particle size distribution, using models of different sizes and flow rates of different profiles. You also now have the option of using computational methods to supplement your application. You can compare your test and innovator lung deposition using in silico simulations. So this is work that's really been pioneered by Worth Longest and Jan de Backer over at Fluidda. And finally, I see my career coming full circle, where for the first time, the FDA is advocating the use of an in vivo bioequivalence study using a pharmacokinetic method. And this was work led by Gunther Hockhaus, Rob Price, Jag Shur, in which we participated measuring the in vitro lung dose that was informed the pharmacokinetic analysis. So Jan de Backer said something very interesting a few months ago at the Palmer conference. He says, FDA are changing. I truly believe they are, and it's being driven by this research. So I want to switch gears now and talk about how we can use the methods that we've developed as regulatory tools to try and inform and guide our device and formulation development for particularly challenging patient populations, where clinical trials are often difficult to do. And our particular interest is developing a formulation and delivery for premature infants. So these are these babies born 1 to 2 kilogram birth weights. They're born with respiratory distress syndrome. They're struggling to breathe. So what is RDS? Well, premature infants are born often lacking the ability to produce their own lung surfactant. The type 2 cells in the lungs are not well enough developed. They don't have enough surfactant, and so they develop RDS. Very soon after birth, they present as being tachycardic, tachypenic, they're cyanosed, basically struggling to get oxygen into the lungs, and these are critically ill babies at this point. So what is lung surfactant? It's this naturally occurring combination of phospholipids. DPPC makes up about 50% of the phospholipids in our lungs. There's a small amount of surfactant proteins in there that are believed to help function, form the monolayer. The surfactant mixture lines the alveolar interface. It reduces the surface tension at that interface and allows respiration to take place. So it allows our lungs to expand during inhalation and prevents them from contracting during exhalation or collapsing. And really, it works to minimize the work of breathing that these infants have to do and maximize the lung compliance, or the expandability, the elasticity of those lungs. These babies are critically ill. Good news is there is a life-saving therapy available in the form of animal-derived liquid surfactant therapy that's delivered as a liquid bolus into the lungs of these infants. 3 steps involved in the delivery of the liquid surfactant. First of all, these babies need intubating. You can see from the image here, it's challenging for the physician it's traumatic for the babies as this small tube is inserted into the throats. What happens next is the liquid surfactant is poured into the lungs of these infants, often at very high volumes. Basically, you're drowning these babies. It makes it very difficult for them to breathe once they've got the lungs full with liquid. Babies are often rotated to ensure we have good distribution of the surfactant throughout the whole airways, very crudely done. Finally, the babies are put on mechanical ventilation. So each of these 3 steps are associated with significant risks, side effects, and the potential for lung damage. These infants often go on to develop bronchopulmonary dysplasia later in life, but it is a life-saving therapy. However, neonatal RDS still remains a leading cause of infant morbidity and mortality worldwide. If you look at the graph on the right-hand side of the screen here, you can see that there are unacceptably high rates of mortality in both low and middle resource income countries, although we're at relatively low rates in high resource environments. And this really comes down to the fact that this life-saving treatment isn't readily available in these low and middle resource income countries. The high cost of the animal-derived surfactant is prohibitive. Combined that with the lack of skilled personnel, you need a clinician to intubate these babies. We need ventilators in order to keep them alive for this invasive therapy. So for the longest time, a non-invasive approach to delivering surfactant has been something that we've been interested in. So aerosol surfactant delivery has been envisaged for many years. I've got to pay tribute to the work of Aerogen. Andy Clark and Jim Fink have been working for a number of years now developing a nebulized version of an aerosol surfactant formulation, and that's currently in clinical trials. But even Jim and Andy will recognize that there's still a number of challenges to this delivery in these infants. First of all, the high dose of a formulation that we need to deliver. For liquid installation, we require anywhere between 1 to 200 milligrams of phospholipid per kg. For the nebulized studies, we've been using anywhere between 2 to 800 milligrams of phospholipid per kg. This is a large amount of formulation that we're putting into these babies' lungs. We truly don't know with actually a targeted delivery how much drug is needed at that interface in order to have a therapeutic effect. Another challenge is the administration time. Nebulizers maybe takes up to an hour in order to get the dose, and they may need repeated dosing. We're hopeful for a powder delivery, we can complete that delivery in a matter of minutes. Finally, there's the neonatal lungs themselves. These premature infants have fragile lungs. The lung volume is about 10 mLs. The flow rates that can be used are very low, less than 3 liters per minute in order to inflate the lungs. If you compare that to how we normally make a dry powder inhaler, we're typically using flow rates of between 60 and 100 liters per minute, volumes of 1 to 2 liters. So a real challenge to make a dry powder inhaler device that's going to be suitable for administration to neonates. So when we look to set our target product profile for our powder product, we set a pretty stiff challenge to our engineers. We want to be able to aerosolize about 30 milligrams of our powder formulation as a small particle powder surfactant aerosol. We really believe this 1 micron aerosol is going to be needed in order to penetrate deep and reach that alveolar region where we're going to have our therapeutic effects. And we're going to aerosolize this formulation using about 10 mLs of air at a flow rate of less than 3 liters per minute. And we're going to do it in less than 300 milliseconds because these babies are breathing rapidly. And in order to catch the inhalation cycle, we need that rapid delivery. So our work in this area started off a number of years ago. This is some work done by Susan Bock, my PhD student, where she took liquid Savanta, which is an animal-derived product. She spray-dried it, turned it into these really nice 1 micron aerosol particles that we then administered via a rat Airjet DPI into a rat surfactant depletion model. And you can see on the left side of the screen some images of the fluorescent aerosol distributed well throughout the lungs. But then when we came to look at efficacy of this formulation, in terms of compliance, elastance, and resistance, we saw improvements in these respiratory mechanics at really low doses of the aerosol formulation. We were able to deliver doses 30 times lower than the liquid doses and get better improvements in lung function. And so for the first time, we were a little bit skeptical of the efficacy of our powder formulation, a little bit surprised, but we started to believe that maybe if we are able to target 1 micron particles to the peripheral airways, less maybe is more. So at this point, we started to work with the Gates Foundation. The Gates Foundation was very interested in us developing our powder device and formulation for a low middle income resource environment. This is a big picture overview of our product that we're developing. We've transitioned from an animal-derived surfactant product to a synthetic product now. We spray dry the formulation into micrometer-sized particles and then aerosolize it in our air-jet dry powder inhaler. The DPI consists of an aerosolization chamber. We have an air source to generate the aerosol. This is our hand actuator here that we're going to use in our low-resource environment. We have a pressure monitoring and control unit so that we don't overpressurize these babies' lungs. And we have a variety of interfaces. What you see on the slide here is the nasal prong interface for direct-to-infant delivery. So we insert the prongs directly into the baby's nose. The data I'm going to be showing you later in the presentation is an endotracheal tube interface for ET delivery as well. And then we're going to use our excipient enhanced growth strategy where we start off with very small particles that are able to penetrate those upper airways and use hygroscopic growth then to ensure that the particles that penetrate into the alveolar region increase in size, deposit, and remain in the lungs. So here's an overview of our spray drying process and our formulation composition. A lot of people have worked on the spray drying over the years. Zhongzhu Son started off way back many years ago developing the original EEG formulation. Serena and Amer worked on the Buki nano spray dryer for the longest period before we transitioned with Mohammed and Felicia here, working on our preclinical batches using the new S300 mini spray dryer. Formulation consists of our 2 phospholipids that are endogenous in the lungs, DPPC and POPG. About 60–65% is phospholipids in our formulation. We have a peptide mimic, a protein mimic. It's a peptide developed by Franz Walther called BYL. It serves as a mimic of surfactant protein B. It's there in a small fraction. We have our hygroscopic excipients, small amount of mannitol, a small amount of sodium chloride, and then we have leucine in there at about 20% as our dispersion enhancing agent. We spray dry them to produce these really nice micrometer-sized particles that are easily dispersible, even at these low dispersion pressures. So we think we have a good formulation that we're ready to take forward to put into our devices. And here's our air-jet dry powder inhaler that's developed by our engineering colleagues, Dale Farkas and Connor Howe, our lead workers on this project. So what's the air-jet DPI? It consists of 3 components. We've got an aerosolization chamber. It has a small diameter inlet and a small diameter outlet. And the key concept here is that the air inlet jet doesn't actually impinge upon the powder bed. It's that secondary turbulence that creates our fine particle aerosol that we emit over multiple actuations. See if I can get the next slide. So when we put all this together, here's our 3rd generation device. This is our infant air-jet DPI. Remember our product description that we described originally? We're going to take 30 milligrams of powder, load it into the device, and we're going to use the hand actuator here in order to aerosolize that powder over 4 actuations of 10 mLs of air at 3 liters per minute and an actuation time of about 210 milliseconds to match that patient inhalation. And what we do in order to generate uniform dispersion over these 4 actuations is we actually maintain a constant distance between the powder bed of the formulation and the headspace in the actuator, in the aerosolization chamber. And you can see the operator there was turning the base of the aerosolization chamber to raise it up. Once again, I failed. I usually try and explain this slide in less than a minute. And I've never been able to do it yet. But it takes a minute to load and deliver the powder formulation. And that's often quicker than it takes me to explain it. In this slide here, you can see the characteristics of those 4 actuations, some spray view images at the top that were generated by Caleb here. In the center, we have the aerosol concentration shown in blue, so relatively uniform aerosol concentration over each of those 4 actuations. And the bottom line message, uniform particle size. For each of those 4 actuations, about 1.5 microns measured by the spray tech. So we have a device, we have a formulation, time to move forward into animal testing. Before we get into our in vivo model, we spent a lot of time using our in vitro model. So back to what we started off with, realistic testing. So what you see on this slide here is our rabbit lung model. Consists of a trachobronchial region that's encased in a lung chamber that simulates the compliance and the resistance of the lungs. And prior to moving into the animal models, we spent a lot of time optimizing our device, optimizing our formulation. Our final composition has an emitted dose of about 80% from the device, so we're able to emit a high fraction of the aerosol. We have a small amount deposited in the ET tube, about 12%. The majority of the dose is in the lower lung, and our total lung delivery is around 88% measured in vitro. This is work done by Mohammed and Dale here, who spent a lot of time developing the in vitro model. So how does that compare with in vivo? This was some work done at VCU by Qinghua Zhu and Rudra, where we took a fluorescently labeled EEG aerosol. And you can see that there was actually pretty good agreement between the in vitro model and what we saw when we looked at in vivo deposition. About 86% deposition in the lung lobes, 10% deposition in the trachea, even deposition across the left and the right lungs, and those yellow areas represent the higher areas of highest deposition intensity. So really uniform delivery across the lung. So we're ready now to move forward into our in vivo testing. The work we chose to do was a rabbit surfactant depletion model, working with Rob de Blasi and his team out at Seattle Children's Research Institute. Rob's a clinician, a respiratory therapist, provides a lot of good insights into what's needed in order to treat these critically ill babies. So what we're looking at here is blood oxygenation levels. So we're looking at PaO2. We start off with a healthy animal, PaO2 between 4 and 500. What we do then is sequentially wash out the surfactant from the lungs, create this RDS state where they have PaO2s of less than 100, and that's maintained throughout the duration of the 3-hour experiment. So when we come to look at the efficacy of our formulation now, what we administered, first of all, was CuraSurf liquid, the standard of care. So we did a liquid installation of 200 milligrams per kg of CuraSurf, just as we would do clinically, and we compared that with our powder aerosol formulation, in which we delivered 2 30-milligram doses. First dose is at time 0, the second dose is at time 15 minutes. The nominal dose of phospholipids that we're delivering here is about 25 milligrams of phospholipid per kg. So an order of magnitude less than what we deliver by the liquid installation. And we see this really dramatic response instantaneously. Within the first 5 minutes, PaO2 is recovered to about 50% of the healthy animal. If you compare that to the relatively slow improvement we see for the liquid administration. We see rapid and complete recovery of PaO2 after that second dose within 30 to 60 minutes. So now, at a dose of 25 milligrams for phospholipid per kg, we're getting complete recovery. So that's a tenth of the dose of the liquid administration. And look at the response profile as well. Rapid response and complete response at a much lower dose. And this is really due to this targeted delivery of this fine particle aerosol deposited in the alveolar regions, no off-target effects. We also looked at lung compliance. So looking at the respiratory mechanics now, the elasticity, the expansion of these lungs. Again, for the liquid surfactant, we see no change in compliance. And that's pretty typical what you see when you think about you're filling the lungs with liquid. It's still in this very early stages post-administration. Very difficult for these animals to breathe. In contrast, what we saw is that rapid response, again, in compliance. 1.5-fold increase after that first dose. And again, we see compliance doubled at the end of our 3-hour experiment. So not only are we seeing improvements in oxygenation, we're also seeing improvements in the way in which these animals are breathing. And what this results in, these are images that really resonate with the clinicians that we speak to. These animals are critically ill. We've washed out all the surfactant. We're putting them on a ventilator. We cause a lot of damage. Look at the hemorrhaging on the surfaces of these lungs in the sham controls. Even in the case of the liquid surfactant animals, we still have a lot of gross hemorrhaging on the surface. The protective action of this powder aerosol gives us these pristine lungs. So these animals have been surfactant depleted, they've been put on a ventilator for 3 hours, and they actually look like they've got healthy lungs. So we're really excited about this. So this is some new data that we've just recently completed. We wanted to look at the effects of removing the surfactant protein mimic, the peptide that's in the formulation. It's expensive, it's obviously going to be complex to formulate. The literature indicates that the surfactant protein is needed in order to help the phospholipids spread at the interface. But all that work's been done with liquid surfactants. It's not been investigated for powder aerosols. So in this study here, we've removed the BYL in the blue line, and you can see that it's had no effect. So removing that peptide mimic didn't appear to alter the efficacy. We still get that same rapid response and complete response within 1 hour after 2 30-milligram doses. Similarly, when we come to look at lung compliance, again, we don't see any change. I think we actually improved our powder handling techniques a little bit to see this improved compliance compared to the original formulation. But again, no negative effects of removing the BYL from the formulation. And this is important for a number of reasons. It could simplify our formulation. It could accelerate our development pathway because now we don't have to deal with the stability issues of a protein in the formulation. So all the work I've told you about so far has been using endotracheal delivery as proof of concept. Obviously, our final aim is actually direct nose to lung delivery. So, just to give you an idea of the size, this is our preterm infant model. Here's our device. The ultimate goal is that we walk up to the baby, we insert the cannulas into the nose of the baby, and then we're going to use our hand actuator to deliver that powder aerosol in less than a minute, direct to infant, almost providing the breath for those babies. And this is what we're working on right now, developing interfaces in order to achieve this. So Hassan is working on the CFD models, Sarah's working on the physical models, and we're really excited to actually make our in vivo efficacy models even more realistic. So that always the challenge with in vivo models is that the upper airways of the animals don't reflect the airways of the babies. So what Rob and his team have been able to do at Seattle Children's is actually incorporate one of our physical airway models into the trachea of the animal such that now we're able to administer those aerosols exactly as we would to our baby in a clinically realistic model. So I'm going to stop here, and hopefully I've demonstrated that the use of these realistic airway models, both in silico and in vitro, have both regulatory and device development applications, shown that we have a powder aerosol formulation and devices that are capable of delivery of a very small aerosol at flow rates and volumes suitable for neonatal delivery, and that the aerosol that we're producing provides both this rapid and sustained response in gas transfer and respiratory mechanics at about 1/10 of the dose of the liquid administration in a non-invasive way. Franz Walther is an MD, worked in this area for many years. He talks about, I heard Nirvana talked about before, in the world of surfactant delivery, we talk about the Holy Grail. I don't say we're getting there yet, but this this photograph that Rob sent us a few weeks ago after one of those good experiments that we did, he says the old Holy Grail is in this container. We were just really happy that Rob's storing the powders in the fridges. Obviously, going to thank our sponsors. FDA obviously sponsored a lot of the model development work. We've had funding from the NIH. The Bill and Melinda Gates Foundation are great partners. They're really pushing us forward with this project. We're looking forward to doing some studies in lambs next year. Finally, I'll just put up the teams that worked on this. Worth's lab obviously develops the devices, does the computational modeling. My lab does the formulation and testing, and then Rob and his team at Seattle did the in vivo studies. Big slide here with a lot of acknowledgements. A lot of people have worked on this, and I'm happy now to take your questions.
Thank you, Mike. Wonderful talk. Really, really fascinating story to listen to. I'd love to have been in the room when you sat down and read out your TPP requirements. We want to deliver 30 milligrams in 10 mils of air at a flow rate of less than 3 litres per minute. I'm surprised you didn't hear the door slam as people exited. So I think fair play to you.
As I say, we work with good engineers. Worth is really the best.
Good. Questions, folks? Any questions for Mike? There's one just over there.
David Morton, Deakin University. Thanks, Mike. Been following your work. Fantastic. One question, when you use the salt and mannitol, I mean, it's something we've all been looking at for a long time. It's pretty well known that when 20% leucine, it actually is a really great protectant against hygroscopicity. I'm just wondering, how have you kind of proven that, or what's your evidence to say the speed at which it's growing and so forth?
Yeah, so it's interesting. Obviously, we have that shell. So if we go look at our moisture absorption uptake curves on the DVS, we have very little uptake in the ambient region, up to 60, 70% humidity. So our product is stable. Once we get it into that 90, 95%, 99% humidity in the lungs, that water uptake is really rapid. Based upon, what's our evidence? It's really computational simulations. So based upon the mass amounts of these materials, the mass amounts are not that large, but the sodium chloride really is enough to give it that growth, and it's really based upon in silico simulations. Thank you.
Time for one more question.
Yeah, Michael, Ralph Niven.
Hey, Ralph.
I'm over here. So, I mean, this is incredible stuff. Having spent years working with liquid aerosols and recognizing the challenges associated with this, I just find it amazing. But the one question, why do you think the lack of the peptide mimic is demonstrating this sort of efficacy? Because I think there's a wealth of evidence showing that the apoproteins B and C are really necessary in lung surfactant. So what do you think is going on?
We really think it's, we had this, one of the guys at one of our collaborators at the Gates Foundation talks about that shower head of individual particles, individual surfactant particles being deposited in the alveolar region. You really don't need that dissolution process because you're really looking at individual one particle, one micron particle. We don't have a rate limiting step of dissolution and spreading of that monolayer. The theory behind the surfactant proteins is really all about the spreading and the interaction to form the monolayer. And we just wonder if the ability of the micrometer-sized particles delivered really efficiently to these alveolar region, takes away that necessity. We were really surprised by the results. The Gates Foundation is pushing us to take more and more things out to see if it still works. We had a lot of skeptics, but we're slowly convincing them that we're seeing that efficacy, and that efficacy is real, even without the peptide. We're going to look in lambs. So I think the next study we're going to do is to move to a real preterm model. So the difference here is obviously we're doing a surfactant washout model versus actually taking animal models where they're born prematurely. Maybe there's some residual surfactant that's still there in the lungs in the washout model, and so that's still a potential as well. So, we have two options. Our two formulations both work well, and I think we can choose which one works best in the lamb model.
Okay, thank you. I'd like to present this to you, Mike. Let's